Alrighty, y'all. Thank y'all so much for coming and joining us tonight for our last journal club in our Rehab Roundtable series. My name is Rhoda, and I'll be the student moderator for this evening. We're so glad you can join us tonight, and we are honored to have our faculty moderator tonight, Dr. Rose Mueller. Dr. Mueller is a sports medicine physiatrist and an assistant professor in the Department of PM&R at the University of Minnesota. She completed her residency at Case Western Reserve University / Metro Health and did her sports medicine fellowship at University of Toledo. She currently practices as a sports medicine and serves as a team physician for the University of Minnesota. Dr. Mueller, if you'd like to take it away from here and introduce yourself a little bit further.
Yes, thank you so much for that wonderful introduction. My patients call me Dr. Mueller, but my peers call me Rose. Nice to meet all of you guys. As she was saying, I am a sports medicine physiatrist, so I did an extra year in sports medicine, and I practice primarily outpatient sports MSK concussion. I do a lot of ultrasound-guided injections, and I also help cover Gopher women's basketball. So that's the D1 women's basketball team at the University of Minnesota. Which is a great time. And then I also do cover a lot of community events, marathons, things like that. I help teach residents in our PM&R residency program. And starting next year, we are going to take our first PM&R trained sports medicine fellow, which is very exciting. So thank you guys for coming here today. I think these are very relevant topics, especially in today's research world. And we're going to have a great discussion tonight.
All right, we'll go ahead and get started with Supriya. If you want to introduce yourself, you can go ahead and share your screen as well and then introduce yourself, what school you go to, and then go ahead and get started. And then just remember that it should be in within the 15 minutes.
That sounds great. Thank you, Dr. Mueller. It's really nice to meet you. Okay, perfect. So hi, everyone. My name is Supriya Bhaskaran, and I'm currently a third year at NICOM on Long Island. And today I'm going to be presenting on sex and gender differences in clinical aspects of physical medicine and rehabilitation. So just a little bit about this. This is a textbook chapter that was published in January of 2024, and it just covers like the different fields of PM&R and some differences when it comes to sex and gender. So rehabilitation is critical for individuals with disabling conditions, and it affects over 2.4 billion individuals worldwide. And while men and women have similar prevalence rates for conditions requiring rehab, women account for a higher burden of years lived with disability. And despite the increasing life expectancy, women are not necessarily living healthier and longer lives. They face a greater social and medical challenges. These disparities make it essential that we understand the sex and gender differences when it comes to rehabilitation. In many cases, women also face greater socioeconomic barriers to accessing services, which further worsens their outcomes. And both biological and social factors affect this disparity when it comes to rehab for women. So starting off with stroke rehabilitation, women experience strokes more so, possibly due to their longer lifespan. They also have a higher prevalence of conditions like atrial fibrillation and cardiac embolism. These factors contribute to greater stroke severity and higher mortality rates. They also have worse functional outcomes, particularly when it comes to motor, cognitive, and language recovery. They also tend to have more severe ischemic strokes as opposed to hemorrhagic strokes, and post-stroke depression is also found more commonly in women, potentially due to the increased social isolation and lower pre-morbid quality of life. And even when we adjust for age and comorbidities, women still tend to have worse rehab outcomes when it comes to stroke rehabilitation than men. And then moving on to spinal cord injury and traumatic brain injury, men actually account for 80% of spinal cord injury and TBIs. One of the possible explanations that this article mentioned was risk-taking behaviors. They also indicated that TBI in men is more so has to do with sports or accidents, whereas in women, it mostly has to do with falls or partner violence. Research also suggests that female sex hormones, particularly estrogen and progesterone, offer neuroprotection that could protect them or help them heal from these TBIs. These hormones work to reduce inflammation and promote the integrity of the blood-brain barrier. This results in better immune regulation, reduced secondary damage, and improved functional recovery in women. This also highlights a possibility for why postmenopausal women often have worse outcomes after a spinal cord injury or TBI. And then moving on to amputation rehabilitation, women are less likely to receive a prosthetic leg or undergo rehab after amputation when compared to men. They also undergo their first amputation at an older age. This is also possibly due to estrogen's role as it protects against atherosclerosis, which is one of the leading causes of amputations. And women also tend to undergo transfemoral amputations more so than transtibial. And this is a more complicated procedure, and then also has to do with a more complicated post-procedure rehab process as well. And one of the concerns that this paper brought up was aesthetic concerns and limited availability of compatible footwear and other prosthetic equipment when it comes to women. And this can also negatively impact the experience women have after having an amputation. Okay, now kind of moving into like anatomical considerations and kind of more into the sports injuries field. So the difference in body composition due to hormonal reasons occurs after puberty, so around 12 years for women and like 13.5 for males. During this, for women, the pelvis widens, you get acetabular anteversion and pronounced genu valgum, which is just kind of like the inward bending of your knees. And during this, through this process, the femoral head is excessively covered, which could lead to impingements. When I read up on this, it didn't say that it impinged on any specific nerve, more so kind of irritates the genitofemoral or the ilioinguinal, which could just lead to like groin discomfort and pain. And then going into ACL injuries in women, women experience ACL injuries 2 to 10 times more frequently doing the same sports or even the same activities. One of the possible reasons for this is their increased Q angle. They have one of around 17 degrees, whereas men it's around 14. So the larger Q angle causes like a medial tilt when it comes to the femur, which puts pressure and causes more of a valgus stress on the knee, which could lead to more injuries. One of the possible ways to fix this is strengthening the hip abductor muscle. They actually found that a larger valgus force on the knee is inversely correlated with the maximum strength of the hip abductor muscle. So this could be something that could help protect women against knee injuries. Also, when landing, in women, the quadriceps femoris is more dominant than the hamstring. So this doesn't allow the knee to flex properly. So that puts a lot of stress on the knee, and it also causes the tibia to kind of move more anteriorly, which could cause more stress on the ACL. And there's also a debated role of estrogen and relaxin, especially during the follicular phase of the menstrual cycle in women, leading to more laxity of the joints. This could also make them more prone to ACL injuries. And because of these factors, people were wondering if sex-specific total knee replacement devices should be considered. However, there was one study done that showed that just the traditional total knee replacement, women actually had a better outcome than men in that study. So that's something to keep in mind. But then again, it was just one study. So I think that could be something that could be looked further into. And then body composition and metabolism. Women tend to have a higher body fat percentage, whereas men have a lower one. It's also important to note that fuel is really important or nutrition and fuel is very important when it comes to training and athletics in women. Something that's common is the female athlete triad. So this kind of involves an imbalance in the hormone levels, menstrual disorders, and impaired osteogenesis. Because of this, they face more stress factors. Kind of similarly, or going off of that, they also have something called relative energy deficiency in sports. And this is just if you're not getting proper nutrition and exercising too much, it could cause irreversible damages. So just important to kind of stress to our athletes, like how big nutrition is and taking care of their body. And then in muscle physiology, there's no actual difference in muscle strength per cross-sectional area when it comes to men and women, but since men tend to have increased muscle mass, that's why you get the overall muscle strength increase. Hormones also influence muscle physiology, so testosterone increases type 2 muscle fiber synthesis, and this is like the fast twitch muscle fiber, whereas estrogen increases type 1 muscle fibers. So this helps with endurance and a faster recovery rate in women. And then women have smaller hearts, reduced cardiac output, and lower maximum oxygen uptake when it comes to compared to men. And this is due to lower blood volume, red blood cell content, and hemoglobin concentration. During exercise, women rely more on increased heart rate rather than stroke volume to meet the oxygen demands. Additionally, lung capacity and oxygen transport ability are lower in women, which may influence endurance and rehabilitation strategies. And just a little bit on general disability rehab. The most prevalent disabilities for women is usually physical at 21%. Not a very close second is auditory disability. And the percentage of women with disabilities is significantly larger than men. You can see it's around 60 versus 40, and this is in the 65 plus age group. And women with disabilities face reduced healthcare access, possibly due to increased comorbidities and social limitations. Even getting to rehab can be an issue for a lot of women. And also a lack of opportunities, whether it be education or career, can also decrease the financial means that it takes to get rehab. So that's something to consider as well. And these are just some of the questions to consider, how we can adapt to these changes, further research into hormonal differences when it comes to rehab outcomes, and if we should explore sex-specific implants, and how we can kind of manage the socioeconomic barriers that come into play when it comes to rehabilitation. And conclusion kind of just says the same as the questions. So both biological and social factors contribute to these disparities when it comes to sex and gender in PM&R. There's some research gaps in investigating underlying mechanisms and evaluating new therapies. One of the possible goals could be personalizing rehabilitation, tailor programs to not just sex-specific needs, but patient-specific needs. And it also takes like a multidisciplinary approach, integrate like medical care and social care just to make sure that we get the best outcome for the patient. Thank you.
Great job. I will say my hill to die on in clinic is that We should absolutely have gender-specific knee braces. I'm not a surgeon, so I can't speak on knee replacements, but frequently in my clinic, I have a female come in, she has a knee injury or arthritis, and she needs a hinged knee brace. And we bring in, whatever, insert big name company of knee brace manufacturer here, and they try it on, it just does not fit. Whereas it more universally fits my male patients because, well, part of the reason is they were designed for male patients originally. So it makes sense that they are not one size fits all, just because there's so many differences in body habitus, in Q angle, in genu valgus and varus, in like thigh. Women tend to have larger thighs than men in general. And so braces may be too small. And I see it very, very frequently in clinic that it's frustrating for me and the patient that we can't find a knee brace that adequately fits the patient and they have to go elsewhere. So I agree that's a hugely important topic and only the kind of tip of the iceberg when it comes to individualizing treatment for different patients.
Absolutely. Thank you both so much on your insight on that topic. I think it definitely brings a lot of great things up that we can all continue to think about and look into on our own time. All right, so we're gonna get ready for our next presenter, Danielle. So go ahead and share your screen and we'll get started. Thank you so much, Supriya.
All right, perfect. Okay, my name is Danielle. I'm a third-year medical student, Sam Houston, coming to you live from Texas. And the paper I'm presenting today is called Physiatry and the Needs of LGBTQIA plus Patients. So I was very happy and excited to see a paper like this existing in the literature, although a little bit kind of alarming how recent it is, 2024, the first time I see a topic quite like this. And I'm pretty honored to be constructing a dialogue around this important work. Okay, so what's this paper about? So this study looks at a very unique and understudied overlap, and that is specifically the LGBT patient experience in PM&R care. There's not a lot of data around that, and so this paper kind of does a good job dissecting some of the barriers in rehabilitation access, clinical competency gaps, and systemic challenges going beyond the traditional interpersonal provider level challenges that we more commonly hear about. And this paper also goes into some of the unique healthcare disparities and the constituents of those disparities affecting the patients in this community. Okay, so why does this topic matter for a PM&R audience? So whenever we think about modern day LGBTQ plus disparities, we have to trace it back to the history of the 80s HIV and AIDS crisis. And unfortunately, our patients and our community is still experiencing the ramifications socially, societally, and in the healthcare context of those biases that were propagated and amplified since then. And there is data kind of capturing some of these challenges, right? So a 2017 survey shows that when we specifically look at LGBTQ survey respondents, so kind of separately from the transgender sub-demographic, 6% of LGBTQ survey respondents in the study experienced refusal of care by a medical provider. And on the other hand, transgender patients, 12% of them in the survey reported experiencing refusal of care by a medical provider. And alarmingly, 29% of transgender patients experienced unwanted physical contact from a healthcare provider, which I thought was quite alarming and horrific. A 2019 study, a little bit of a narrower focus, it looked at school and sports teams, and they were one of the most common settings for verbal and physical assault, and that was reported by over 50% of the respondents identifying as sexual or gender minorities. So also over the course of a lifetime, LGBTQ plus individuals are more likely to experience acquired disability, and there's a lot of social determinants of health that help explain this, and that's kind of lifelong disparities in access to care, rehab care, and otherwise chronic health conditions that might go uncared for, lack of community, if there's not a reliable support system, and as well as mental health stressors are also important to think about and very much relevant to rehab recovery outcomes. So barriers in PM&R include implicit bias from providers. So that's like the individual communication level and quality of care, all that stuff. And lack of standardized LGBTQ plus competency training in rehabilitation medicine, some programs location-wise, or maybe if there's faculty that have interest in this topic, they might get a little bit exposure to this patient demographic, might get a little bit more training, but that's not always true across the board. And of course, insurance, legal barriers, and stuff like that. That's important to the day-to-day living of our LGBT patients. Again, kind of this issue is understudied in PM&R, making work like this that much more important to take a step towards improving rehabilitation equity. Okay. So bird's eye view, right? This article set out to explore the unique challenges faced by LGBT patients in rehab medicine and also evaluate gaps in clinical knowledge among physiatrists. And some of the key findings were that LGBT patients do, in fact, seem to report lower satisfaction with physiatric care, partially due to perceived lack of provider knowledge on their needs. Now, transgender patients face additional barriers in rehab. Some of these details being gender dysphoria can be exacerbated by poorly adapted care plans, a lack of PTOT protocols that account for hormone therapy effects on muscle recovery. And this also extends to, like we kind of recently discussed, the assistive device and kind of adapting to the biology of our different genders, and as well as these patients, their body habits just evolve as they're receiving gender affirming care. And also, unsurprisingly, post-surgical rehab after gender affirming treatments are often not covered by insurance. And intersectionality is a huge important concept that's kind of a through line throughout this topic. LGBT patients of color and LGBT patients from a background of financial adversity do face compounded and often additive disparities. Okay, so we're not just here to talk about problems and disparities, right? We're also thinking about solutions. What can we do? So as PM&R trainees and providers, we are pretty well positioned to ensure continuity of culturally competent care in the therapy professions that work in concert adjunctively with us in PM&R. So particularly, I learned about speech language pathologists who were discussing this paper. They often support patients, transgender patients, with the voice changes, the often uncomfortable voice changes that kind of transpire while receiving gender affirming care or hormone therapy. And they have a unique role in kind of supporting these patients through that transition. So it's not just mental, emotional, physical changes. There's also like the voice and kind of adjusting to the systemic effects of the hormones that are being administered. And this is a pretty big topic. I'm going to briefly touch on this, but advocating for transgender people in sports and recreation is an important thing that we can do, right? So, whether it's the Olympics or national level or state level, there's a lot of discriminatory legislation that, there's nuances there. There's a lot of debate about the competitive advantages or the fairness of allowing transgender athletes to compete with their cisgender counterparts. And there's nuance there, right? But in these conversations, we talk about so many things, but often we don't talk about is the effect that we're having on the transgender people or athletes themselves by excluding them from the enterprise of athleticism and sports and recreation. And that's an important part of the human condition. And we're sort of choosing to construct a culture that excludes this demographic from that entirely, which is kind of sad, right? And on the other hand, physiatry recognizes the importance of physical activity for all people. So we are in a unique position to be able to support vehicles of advocacy in this arena. Okay, so what does this article do pretty well? So it brings some much needed attention to the topic period, LGBT disparities in rehabilitation medicine. There's not a lot of work out there talking about this. Also, it identifies specific barriers, not just at a surface level, but kind of dissects lack of competency training, insurance limitations, caregiver recognition issues, and calls for larger systemic changes in medical education and policy, kind of moving beyond just the typical pronoun awareness and individual provider biases that are more commonly discussed. And this article does a great job providing a foundation for further research in LGBT rehabilitation care. I mean, this article came out 2024. We do have a long way to go. Limitations and critiques. So lack of empirical data, right? This article is more constructed as a narrative commentary from my reading of it, at least. Not a ton of So basically pulling from anecdotal evidence and literature reviews and a few survey data rather than original patient studies or cohort studies or things like that. And this paper does do a good job calling for better training, but as far as clear clinical guidelines and specific competency goals for what a curriculum can successfully do or what outcomes would be important to measure the effectiveness of this training for PM&R clinicians, that is a kind of not really illuminated, so to speak, and no long-term outcome studies. So rehabilitation is often a lifelong process, right? And we do lack research on LGBT patient outcomes over a longer duration of time. Okay, and so there's interpersonal stuff and there's cultural stuff, but this article doesn't quite get into PM&R relevant musculoskeletal, urological, and neurological complications of gender affirming surgery, and I kind of had to pull from like a AAPM&R knowledge now video module to kind of talk about some of this data, like and this is getting into like the medical knowledge piece that I would have liked to see in this article. So when we think about top surgeries, there's uh, complications of that PM&R has an important medical role in tending to. So that includes post-breast surgery pain syndrome, capsular contracture, among other things. When we think about complications of bottom surgeries, on the other hand, that's metoidioplasty, phalloplasty, penile implants, and conversely, vaginoplasty. So there's a lot of things that can happen subsequent to that, right? Necrotic flap failure, anorgasmia, urethral injuries, and a variety of pelvic floor disorders that are important for us to be cognizant of and trained in the treatment of. Okay, so why do LGBT individuals experience their disability differently and sometimes additively? So some important concepts that I was able to boil down here, there is a thing called double marginalization. So when we think about LGBT individuals with disabilities, they're dealing with ableism and homophobia slash transphobia. So that compounds their barriers to care, right? Conceivably so. Disability and gender identity. So trans patients may have musculoskeletal differences that they're also kind of uh, newly adjusting to due to the hormone therapy, and that impacts their PTOT needs. So as providers, we're often dealing with these evolving physical changes, and we're kind of in a position to support the patients as they're discovering their evolving body habitus. And I think that's pretty a cool opportunity to be doing that medically. And assisted devices, prosthetics, wheelchairs are often and knee braces, right, are often designed for cisgender bodies, even then predominantly male bodies, leading to discomfort or dysfunction when we try to adapt these assistive devices to a wider patient population. Okay, healthcare mistrust. We kind of touched on this already. A lot of these patients avoid seeking rehab care due to past medical discrimination that they've experienced. Unsurprising. And now social support structures. So many of these patients rely on chosen families, and they might not have legal caregiving rights. And a lot of these legal rights and allowances are under jeopardy as well in the current climate, which we won't get into too much. But this does complicate relevant to us discharge planning and long-term care and supporting our patients and building that therapeutic alliance. So it does behoove us to be aware of that. Okay, so where does this article fit into the grander PM&R and medical literature? This was one of the first PM&R focused papers addressing LGBT disparities. The field has expanded since then. There's some more data on adaptive sports and LGBT inclusion in that capacity, some more data about gender affirming post-op rehab, curriculum changes, some information about insurance coverage. So some work has been done. But some gaps do remain, do linger. There's still very few clinical guidelines on LGBT rehabilitation care. Few of it exists, let alone standardization, right? So we do need more empirical and patient-centered research rather than theoretical narrative discussion as well. So conclusions, LGBT patients do experience significant disparities in rehab due to bias, lack of provider education, systemic factors, just to name a few. And this article sheds light on empirical research, raises awareness, but also highlights the need for empirical research, standardized training, and policy change. What we do need to flesh out from this point on is more specifically what kind of empirical research, what kind of clinical guidelines, what kind of training milestones and specific policy changes do we need to be calling for? So as future physiatrists, we must proactively create inclusive rehab environments instead of always just trying to catch up. We need to be ahead of the curve here for the sake of our patients. I have some discussion questions that we may choose to circle back to at a later time in this hour. These are my references that I pulled from, and I just wanted to part us with a powerful quote that I really like going back to in times of helplessness. This is by Tammy Baldwin, the first lesbian senator in the US. And this goes, equality is not something we achieve and then move on. It is a constant struggle and ongoing fight to ensure that future generations do not have to relive the battles of the past. And, taking steps like this, being in attendance here on a Monday evening, listening to dialogues like this, you guys are already making a huge step in the progress and the fight towards change. So thank you for doing that. And thank you for listening. This has been my talk, and I appreciate your attention.
Thank you so much, Daniel. I think we all feel very inspired by that. Also really loved your graphics. Dr. Mueller, if you have any comments, you can go ahead, and then we'll get started with the last one.
Okay, great talk. I mean, I think we could talk for, the entire time about each of these topics really, but I thought that was a great final point in that inclusion helps everyone. Inclusion of women, inclusion of LGBTQIA patients, thinking about just let's take the knee brace example. Let's include that for non-binary people. Let's include that for people transitioning. Let's include that for women. Then we get this large variety of sizes and styles and shapes that helps everyone's body habitus, regardless of their sex or gender or, disability. And that's just a great, I think, moral of this talk is that if we remember to be more inclusive, it improves care for everyone.
Absolutely. Thank you so much for that insight. Alrighty, we'll get started with Porus on the last presentation. Thank you both again.
Hi, everyone. My name is Porus Francis Palupeta, and I'm a third-year medical student at Lake Erie College of Osteopathic Medicine from the Erie campus. Today, the article I'm going to be presenting on is on considerations for long COVID rehabilitation in women. So just a brief intro for everyone. Long COVID is known as the post-acute sequelae of SARS-CoV, and it refers to a range of symptoms that persist for weeks or months after the initial COVID infection has resolved. So while many people recover from COVID within a few weeks, some individuals, regardless of the severity of their initial illness, experience lingering effects that can significantly impact their lives. So some common symptoms of long COVID include fatigue, shortness of breath, cognitive issues, often referred to as brain fog, joint and muscle pain, sleep disturbances, headaches, heart palpitations, loss of taste or smell, and depression and anxiety. So long COVID presents a lot of unique rehabilitation challenges since we're still in the process of understanding it, and women experience very distinct symptoms and complications. So PMR can play a crucial role in improving patient outcomes. So here are some quick facts on the epidemiology of long COVID in women. So studies indicate that women are more likely than men to experience long COVID, and this is due to a variety of things. So generally symptoms persist beyond 4 weeks, with some lasting months to years. So one of the reasons behind this is the differences in the immune response. So women generally have a more robust immune response compared to men, which may help in fighting initial infections, but can also lead to a heightened inflammatory state that prolongs symptoms. And this overactive immune response may contribute to persistent symptoms seen in long COVID. Another big factor is hormonal influences. Estrogen has been shown to regulate immune function and inflammation, and the fluctuation or decline of estrogen levels, particularly in perimenopausal and postmenopausal women, may impact recovery and increase susceptibility to chronic symptoms. In addition, women also have a higher prevalence of certain pre-existing conditions. So women are more likely to have certain conditions like fibromyalgia, chronic fatigue syndrome, and certain autoimmune disorders, which can share overlapping symptoms with long COVID. So these pre-existing conditions can predispose women to prolonged post-viral symptoms, further compounding the recovery challenges. So some common symptoms seen in women with long COVID include fatigue and post-exertional malaise, which can severely impact their daily function. The cognitive impact or brain fog, which can lead to difficulties in concentration and memory, and various dysautonomia symptoms, including POTS, which stands for postural orthostatic tachycardia syndrome. It's a form of dysautonomia that affects circulation, causing the heart rate to increase significantly when a person moves from lying down to standing up. Orthostatic intolerance and various heart rate irregularities. A woman can also experience joint and muscle pain resembling fibromyalgia, and sleep disturbances and mood disorders such as anxiety and depression. So here are some of the mechanisms behind long COVID in women. One of the big ones is immune dysregulation. So as I had said before, women typically exhibit a stronger innate and adaptive immune response compared to men. And while this can enhance the initial viral clearance, it can also lead to an exaggerated and prolonged inflammatory response. For example, elevated levels of pro-inflammatory cytokines like IL-6 and TNF-alpha have been found in women with long COVID, leading to persistent systemic inflammation and damage, tissue damage. Endothelial dysfunction and microvascular injury. So COVID has been shown to affect the endothelial lining of blood vessels, causing inflammation and clotting abnormalities. So women with long COVID often experience symptoms consistent with microvascular dysfunction, such as post-exertional malaise, chronic fatigue, and dysautonomia. And this can explain why some women may experience chest pain, shortness of breath, and exercise intolerance, despite normal cardiac evaluations. And also the hormonal influence and estrogen regulation, as I had discussed before. There's also the autoimmune predisposition. And some emerging research also shows that mitochondrial dysfunction and energy metabolism may be another factor. So COVID may impair mitochondrial function, leading to inefficient energy production. And women with long COVID frequently report severe fatigue and post-exertional malaise, which could be linked to the mitochondrial dysfunction. Reduced ATP production results in cellular energy deficits, exacerbating symptoms like cognitive dysfunction and muscle weakness. So some general rehabilitation strategies that we could use in PMR include a multidisciplinary approach combining physical, cognitive, and psychological therapies because it affects all these different things. Pacing and graded activity programs to prevent symptom exacerbation. Cognitive rehabilitation using structured exercises to restore mental clarity. Autonomic rehabilitation for dysautonomia and postural instability, and mental health integration through counseling and stress management techniques. So in terms of addressing the fatigue and exertional intolerance that can come with long COVID, there's a thing interesting I read in the article about the spoon theory, and this was online blogger came up with this theory, and it's a metaphor used to explain the limited energy and resources of individuals with chronic illnesses, including those with long COVID. So in this theory, each spoon represents a unit of energy or capability for a day. And people with chronic conditions start each day with a finite number of spoons, which they must use to manage the daily activities and responsibilities they have. So for women with long COVID, this theory can be particularly relevant because they may experience a range of symptoms such as fatigue, brain fog, and physical discomfort, which can significantly impact their levels. And as a result, they have to be mindful of how they allocate their spoons throughout the day. Pacing strategies are important, so limiting your exertion to avoid post-exertional malaise, and having adaptive exercise regimens such as low-intensity physical therapy with slow progression. In terms of managing the dysautonomia that can come with long COVID, fluid and salt intake optimization to manage blood pressure fluctuations is important. Compression garments can help to enhance circulation and prevent dizziness, and gradual cardiovascular conditioning through recumbent exercises before upright training. In terms of cognitive and neuropsychological rehab, so memory and attention training through digital applications and structured tasks is important. Neuroplasticity-based therapy focusing on cognitive retraining techniques, and behavioral sleep interventions to improve restorative rest and minimize brain fog. And it's also very important to address the psychosocial considerations because, as I had mentioned with the spoon theory, people have a limited number of spoons. So it's harder for women to deal with their days when they have to balance all these things. So mental health burden, there's an increased prevalence of anxiety, depression, and PTSD. There's an important role definitely with the family, patient advocacy groups, and peer support because it's still a disease we're still trying to understand. So it's important that women can understand what they're feeling is real. And holistic rehabilitation programs that incorporate psychological well-being. Some barriers to care for women with long COVID, there's still gender bias in medicine, so the under-recognition of women's symptoms. Limited access to specialized rehab, so there's definitely a need for more PM&R clinics addressing long COVID, and I've been hearing how there's been issues finding funding for a lot of these long-term rehab facilities. And the stigma of invisible illness, and it's definitely important to validate patient experiences, especially in a disease as new and still being understood. In terms of the role of PM&R physicians, it's important to have a patient-centered approach, focusing on individualized rehab plans for each person, individualized interdisciplinary collaboration with cardiology, neurology, and mental health professionals, because long COVID can affect all these body systems. And there definitely needs to be more advocacy for increased research in sex-specific long COVID rehab strategies. One thing that I thought could be important also from reading this paper is the development of specific biomarkers for diagnosis and targeted treatment. So that's probably going to come along as we understand the disease as we understand the disease more as well. And also the expansion of rehabilitation services, as I said, to improve access to care. So overall, here's a quick conclusion of some of the points I made. Women with long COVID face unique rehabilitation challenges requiring tailored interventions. PM&R physicians have a critical role in developing effective recovery strategies, and further research and policy changes are essential to improving outcomes. Thank you all for your attention. If you have any questions, you can let me know.
I think great talks today, guys. The common theme, of course, in this whole series is we're talking about groups of people who are typically underrepresented in both research, in medicine, and in general. And so this is a great start. As I think all of you said, advocacy is really important. So first, knowing that there is a problem, which is that we don't have enough research. And then two is making other people care about that problem so that we can get this funded, because research, unfortunately, just does not happen without funding. It's not realistic. And then advocating for that, getting other people involved, and spreading the word. And so I think what's very unique about your generation of medical students is that social media is so rampant, and you have that as a tool to share all of the things that you know and all of the things that you have learned. And although it can be a huge tool for misinformation, it can also be a huge tool for, information. So, remember that you are going to take the Hippocratic Oath. And at one point, Hippocrates thought that women were hysterical because their uteruses were moving around their bodies. So we've come quite a long way from there, okay? But there's still a lot of misinformation about women, about minorities, about LGBTQ people. And we need to work to address those as good physicians and make sure that you can treat your patients as individuals. And that really includes understanding them. So part of being a good doctor is not just knowing the medicine, it's knowing about your patients so you can provide the best individualized care for them.
Thank you so much, Dr. Mueller. I think your insight has added so much to our perspective. As students, we obviously don't have, like you said, a lot of our experience with this from social media and like pursuing it on our own terms. So it's really nice to see, your passion and experience, and thank you for taking the time to share that with us. Would like to open the floor for any questions right now. So please raise your hand or put them in the chat if you would like to. And I do have a few questions that were submitted beforehand, but we can take some now if anybody has any. Jackson?
Yeah, I have a question for Dr. Mueller. Just going back to Daniel's presentation, I was just wondering, how we could advocate for LGBTQ athletes, and if you've had an opportunity to do that in your career.
You know, that is a really great question. And so part of, the LGBTQ athletes, or specifically transgender athletes, are on the table right now. I'm sure you've heard about it in the political sphere, but there's a recent executive order that said that transgender athletes will no longer be able to compete in NCAA sports. And so just to put that type of a thing into perspective, there are over like 500,000, I think, athletes. I'm gonna say probably the wrong number. I should look this up. But in NCAA, so 530,000 student athletes in NCAA, and there are less than a dozen that are transgender. So put this into perspective, we are making a very, very big deal about something that is pretty rare. And as Daniel was saying, the argument is that, well, it's not fair to the athletes that are not transgender because, and this is only for, I'll specifically say that transgender men are still allowed to compete with males. Transgender women are no longer allowed to compete with the female designation. So it only affects transgender females, not transgender males, at least currently. And so that's probably even less than 10 people. I don't know the exact number, but it's a small number of people. And you do have to weigh the amount of, is it fair to the effects on mental health, physical health, psychological health to these transgender athletes? And I'm not going to pretend that I know the answer and how to make it fair and how to make it equitable. But I do know that having derogatory comments made on social media and television and rampant are not doing anyone any favors, anyone transgender, athletic or not, anyone in the LGBTQ community. It's detrimental to their health. We know that transgender children have significantly higher rates of suicide if they do not receive access to gender affirming care. And so that is the type of thing that, as a physician, I worry about. I worry about my patients' mental health, regardless of their sexual status. And I personally do not work with any transgender athletes. I have a transgender family member that's an athlete that I love very much. And I don't know what the right answer is. I think that more research is always the right answer, because if we can find a way to make it as fair as possible, at least physiologically and chemically, that may make the most amount of people happy. But we also have to know that we're never going to make everybody happy. And we, at the end of the day, have to do what is right for our own patients. But that's a great question.
Thanks, Dr. Mueller.
Thank you so much for that question and your amazing answer, Dr. Mueller. We do have one that was submitted beforehand. Let me just check here. It was, how do you approach conversations about gender identity and sexual orientation with your patients? But I think you kind of answered that, but I don't know if you wanted to add to that.
Yeah, that's pretty good. Remember that, and depends on what EMR you use, but I use Epic. And remember that, like Daniel was saying, and a lot of these patients have traditionally been treated poorly by healthcare professionals. And if you have an experience of being treated poorly by healthcare professionals, you're not going to trust your doctor, understandably. And so when I have a patient who is transgender or non-binary or something that is not, cookie cutter in the system, their records are exactly what you would expect, we now have options to put the correct pronouns, preferred name, and gender identity into Epic. And so I will go into the room and I'll say, hello, my name is Dr. Mueller. My pronouns are she, her. Would you like to share yours with me? And the second question I ask is, what do you prefer to be called? And then I say, if they're not in the computer, would you like me to add your preferred pronouns and your preferred name into computer? And I've never had anyone say no. And I have had a lot of people thank me. If you treat people like they want to be treated, they are going to trust you more, and you're going to get a lot farther, a lot faster. You're going to be able to treat them more efficiently, and you're going to have a better and more rewarding patient-physician relationship long-term.
Absolutely. Thank you so much. Does anybody else have any other questions? If not, the last one was, how can we integrate these competency points or the discussion that we had here today into residency training. And if you had any experience with that yourself and how we can kind of, I'm just adding to this, how we can kind of like pursue that when we're kind of exploring different programs.
You know, that's a great idea. And I think that diversity and equity and, you know, dealing with different patients, it's such a big component of the specialty of PM&R, right? We work with people with disabilities. And I do think that as a whole, we could do a better job of integrating learning about gender identity and race and sex into our training programs. I think that it is not standard in enough programs, probably, and that we would all be better physicians because of it. I think that a lot of it is we've done it this way for so long, we're going to keep doing it this way. And that's just kind of the way things go in every system. It's been like this forever. This is how we do it. And so I would say advocating for change yourself. If you said, hey, program director, I think a good lecture would be this. Women who, let's say, women who get TBIs from domestic violence. Can we learn more about this? I don't think any educator, myself included, would say that's, I don't know. They would say, that's a fantastic idea. Thank you for thinking of that. Let's find a way to integrate that in the curriculum. Would you like to be involved? And so I think that that's showing your professors and your teachers and your attendings that you're interested in learning that kind of thing will go a long way, and that you're interested and that you care. And I think that that's really great for you to advocate yourself. It may not happen overnight. It may not be easy. It may not be standard. And sometimes you have to be assertive with what you want to change, unfortunately. Otherwise, just things don't change. And I think that it was, you know, the people before us that helped get things to the way they were. Again, we're not treating women for like rotating uteruses anymore, because women that have come before us have said, hey, this is not a thing, let's do more research. And they figured out that it wasn't true. You know, you can take any medical stereotype and find someone who advocated for that to not be true, or that stigma to not be true. And so you need to be the advocate sometimes. And I think that if you empower yourself to do that, you will only get good results. And so we are hopeful for you guys as our next generation to continue to advance medicine to the next level.
That's incredible, very inspiring. I think a lot of us kind of have, I guess, hesitancy with approaching different, you know, controversial topics. But I think, like you said, if nobody's going to do that, then it will never change. So really appreciate that sentiment. I think we can all kind of leave this discussion with that in mind. Does anybody else have any specific questions? If not, I can give a chance to the presenters. And finally, Dr. Mueller, for any last comments, if you want to, no worries if not.
No questions, but I just wanted to like echo how inspired I am from all these conversations, and thank you for Dr. Mueller for having those and sharing those ideas about the importance of taking initiative in those active roles, because that's not just in the patient care domain within the walls of the clinic, but also in the educational spaces. And you know, we often hear about find a residency program that's a good fit, but also it kind of falls upon us as trainees to take an active role in developing instructional materials that can benefit us as well as our peers, and by extension our patients. So I really love that sentiment, especially as we're ending towards the tail of our third year, tail end of our third year. It's inspiring and energizing, and galvanizes me to kind of be that much more of an active advocate for the sake of our patients. So thank you so much for sharing that.
Yeah, and you guys are already doing the first step, right? You're here on a Monday night. I'm sure there's something you would rather be doing, but you were learning about, you know, diversity in healthcare on a Monday night when I'm sure that, you know, you could be studying for a test. I think remembering that leadership roles will let your voice be heard more often, right? I said yes to this lecture, and now I get to talk to all of you about this. And now you guys get to talk to all of your friends about this. And then I can feel like, hey, maybe I made a difference today. And that's a pretty incredible feeling for me. That's why I went into academic medicine, because I wanted to do that. And so just remember that volunteer for committees, volunteer for lectures, volunteer for things, speak about things that you're passionate about, and the word will get out. And thank you guys for being here and taking the time to do this. If more med students did this, I think the medical field would be a better place. So kudos to you guys.
Thank you so much. Thank you all so much. Thank you to our presenters for the insightful discussion today. We got to learn a lot more about gender, LGBTQ, and then specifics with things like long COVID. I'm happy to see that research is more tailored toward these marginalized groups and how we can kind of change our outlook as future physicians. And want to give a very, very big thank you to Dr. Mueller for lending us her time tonight on a Monday night, like you said, and all the attendees for taking some time out of your busy schedules to join us. So with that, wanted to a final thank you, and everyone have a good night.